Okay, we're going to start oncology. If you are following along in your book, then we are in chapter 16. Just know that oncology is a specialized field. For nursing, it's actually a specialized field that you can get a certification in. You guys should know that this is oncology is well over 200 diseases that are defined by uncontrolled cell growth. You can also look in your book and see the top cancers in the United States on page 248 by gender, and then the top cancer death rates by gender. For instance, for both male and female, it is lung, and then for male, second is prostate, and for female is breast. We have made much gain over several years, seen a decline in many of the top cancers in the United States, but also seen the 5-year survival rate increase to 68%. When you look at cancer, cancer is defined by defective cell growth and defective cell differentiation. So when we look at defective cell growth, you're looking, what normally happens is cells don't invade other spaces, but cancer cells ignore these principles or properties. And so they do invade other spaces and they grow at an alarming rate. Defective cell differentiation is typically stable and orderly for someone who does not have cancer, but this is not the case when we have cancer. And this is also where your genetic links come into play. When you're looking at cancer, there's essentially 3 stages of cancer that are outlined in your book. And these 3 stages are initiation, promotion, and progression. And we've moved on to page 250. A great picture on page 250. It shows the initiation, some things that might actually initiate cell growth. And some of these things, for instance, could be viruses, hormones, exposure to radiation, certain chemicals, certainly genetic factors, and then there is the always unknowing factor. But what we do know is that this is when cancer cells arise. Then we come down to promotion, and that is just as it sounds. Something then promotes the cell growth or the cancerous cell growth. This is the second stage in the development of cancer, and it is characterized by reversible growth of the altered cells. And so when you're looking again, some things that might actually promote cell growth include the consumption of dietary fats, obesity, cigarette smoking, alcohol consumption, continued exposure to the sun. And then we have what we call progression, and progression means that this stage is characterized by increased growth rate of the tumor. It can invade other organs, and when we have invasion of other organs, we actually call this metastasis. So when we look at cancer, we look at how we actually grade or stage cancer. First, you have to understand the classification of benign versus malignant, and this is on the bottom of page 253. It goes over the characteristics of what would be considered a benign tumor, such as usually it's encapsulated, it's well differentiated, there's no metastasis, usually do not reoccur. And we get into malignant, then it is usually rarely encapsulated and is poorly differentiated and can metastasize. And so those are a couple of things, whether we rate something as cancerous versus non-cancerous. When you're looking at cancer, it's graded upon the cell's resemblance to what a normal cell looks like. If you're looking in your book on page 254, it talks about the histologic grading. Typically there's 4 or 5 classes. You guys don't have to remember this. Just remember that they are actually looking at the cells and they're comparing them to normal cells and realizing that the more undifferentiated they are, the worse prognosis. This is just a picture of it shows you what normal cells would look like versus a cancerous cell. And you can see, for instance, normal cells are usually not large and do not have variables in their shape of the nuclei, whereas this cancer cell does. Cancer cells, as we already said, can divide rapidly. They're usually disorganized as they reproduce. They vary in size and shape, and they lose the cell's normal appearances. Additionally, on this page, you see where we can also stage 0 through stage 4. Whether it's just a cancer that's been diagnosed and it has stayed within its tissue of origin, or it's a stage 4 where there has been metastasis. A lot of times they will use the TNM classification system. The TNM means that there's a primary tumor. Looking at the primary tumor, is there any evidence that it has spread to other organs? Looking at the N, is the lymph nodes. Is there no lymph node involvement, or is there a lymph node involvement that could actually be regional? And then the M, metastasis, is there no metastasis involved, or is metastasis occurred in distant areas? We move on to page 255, and we're looking at the prevention and early detection of cancer, and then we want to make sure that we teach patients and generally the public about cancer prevention and early detection. And so we want to obviously teach them about the things that they should avoid. And we know these. We know that they should avoid, alcohol and cigarettes and sun exposure and foods that are high in fat. We want to make sure that they have healthy habits. We want to encourage a balanced diet, one that includes lots of fresh vegetables and fruits and adequate amounts of whole grains and dietary fibers. And we want them to limit their alcohol consumption. And that also includes to maintain an optimal healthy weight and to exercise regularly and sleep at least 6 to 8 hours per night. We want to make sure that they have their regular physical exams, especially the ones that have been set forth to include having your colon checked by the time that you're 50, or having, your first mammogram by the time that you're 40, or having your first prostate exam by the time that you're 50. There's many routine healthy exams that have been set forth by the American Society of Oncology. We want to make sure, as we said, that they reduce certain poor habits and that they learn the 7 warning signs of cancer. These are outlined on page 255 at the top. They use the word caution. C for change in bowel habits, A for sore that doesn't heal, U for unusual bleeding, T for thickening or a lump in your breast or anywhere else, I for indigestion difficulties, O for obvious signs or changes in a wart or a mole, and N for a nagging cough or hoarseness. As we look at how we're going to diagnose cancer, this can be a difficult time for a patient that you're taking care of when they're going through and waiting for possible test results. And so just make sure that you're aware of your own feelings. Sometimes this can be a difficult situation. You want to make sure that you don't provide false reassurance, such as it's probably nothing, let's talk about that later, or everybody feels this way. When you're looking at page 256, it talks about the different diagnostics. It talks about, for instance, a cytology. We've already talked often about cytology. It's the study of the cells, and so they're looking for cell abnormalities. You can do tissue biopsy in many ways. You guys have seen the different types of biopsies, for instance, of the prostate, a bronchoscopy, that it's just a sample of tissue so we can take a look at it. Your book gives several different types of biopsies, but we're just going to go with the simple term of biopsy as the removal of a tissue sample for pathology. You guys know about a chest x-ray and a CBC, a chem panel, LFTs. We've talked about endoscopic exams. You saw the principle of the scopes when we talked about it for cystoscopy in the bladder, so you could certainly, if someone had possible bladder cancer, we talked about for a bronchoscopy, if someone had possible lung cancer, you can also do a or a scope for upper endoscopy, where you would actually, look at the esophagus and the stomach. You can do it for a colonoscopy, where you can look at the colon, so it just goes on and on. Different types of scans. It shows you a PET scan. PET scans are interesting. They actually inject radioactive material, and you know that the radioactive material accumulates in areas that have higher levels of cell activity, so it would possibly highlight abnormal cell activity. Going down the list, there are certain types of tumor markers. We'll talk about those, and then you guys know about the BRCA1 and BRCA2. There are some genetic markers too that can be utilized for possible diagnostics. You get into, for instance, bone marrow aspiration. I did post on the YouTube channel a good video of bone marrow aspiration. I want you guys to look at this. It's typically done in a physician's office. The patient's not asleep. They usually just get a little bit of local anesthetic to numb the area where the needle is going to be inserted, and they insert a biopsy needle through the skin and down into the bone marrow and take a sample. This is done obviously for your hematologic cancers and possible diagnostics of bone marrow invasion. Post-procedure, you just usually have them lay on the affected site with the pressure dressing to make sure there's no bleeding. You would want to make sure that you talk to the patient about how to monitor the site for infection and bleeding. And, they might need to take some NSAIDs if not contraindicated, or some acetaminophen to treat the pain. And as I said, it is typically done on an outpatient basis. Some of the more specific lab values that you guys might see are, for instance, a CEA. CEA are cancer cells that can be found in the GI tract. The alpha-fetoprotein, the AFPs, these are abnormal cells that can be found in the liver. The CA125 can be found for ovarian cancer. We've already talked about the PSA for prostate cancer. And we would obviously want to look at the CBC, possibly your white count, hemoglobin, hematocrit, and platelets could be abnormal if you have bone marrow involvement or you have a hematologic cancer. Okay, so when we're talking about the management of cancer, it's typically looked at from three perspectives. Cure, when hopefully the goal is that we can actually cure the cancer, that there is a good chance of getting rid of the disease completely. The second would just be control, when the goal is just that the treatment plan would be to eradicate the cancer as much as possible, because doing it completely is not possible. And then palliation, which means that we are just going to provide treatment that will help with relief or control the symptoms of the cancer and hopefully maintain a satisfactory quality of life. So treatment and how they decide what to do is dependent upon the cell type, the size and location of the tumor, the extent of the disease, meaning is there metastasis, the physical and psychological status of the patient, and then taking into consideration the patient's expressed needs and desires as far as treatment goes. Treatment therapy used for cancer focuses on surgery, radiation, chemo, and biological and targeted therapies, and that's what we're going to talk about next. This slide merely summarizes how often things are used. For instance, 90% of the time for surgery cancer, or 90% of the time surgery is used for cancer treatment. And so it's used in the diagnosis and then often is used in the treatment. Chemotherapy is the use of cytotoxic drugs, drugs that are toxic to the cells to cure or decrease the tumor size, or just as adjunctive therapy. And radiation is used to kill the tumor or reduce the tumor size. Sometimes it's used as palliation to either decrease pain or relieve an obstruction that exists. Okay, surgery. Surgery can, when we're following along here, guys, surgery can be used to diagnose. We've already talked a little bit about this. Often is used in the diagnostic process as a biopsy. It can actually be used in the prevention, meaning that if there is an organ that actually needs to be eliminated or reduced to decrease the development of cancer. Sometimes, for instance, a great example is someone who has a genetic mutation such as the BRCA1 or BRCA2, and they have a strong family history, might decide to have a prophylactic mastectomy. It can be used what we call for staging. Exactly how bad is the cancer? Where is the cancer at? What are the lymph nodes involved? That's called clinical staging. And then from there, physicians can decide what is the best treatment option. It can be used to cure or control the cancer. Cure, meaning that it removes the cancerous tumor and possibly tissue that surrounds the cancerous tumor, or control would mean to debulk. Debulking is just when the tumor cannot be completely removed, but it can be decreased in size. So debulking is when the cancerous tumor cannot be removed, but it can be decreased in size. And then it can be used for palliation. Palliation just helps relieve symptoms that's associated with the cancer. For instance, if there's a bowel obstruction related to a cancerous tumor, then they could remove that bowel obstruction. Sometimes reconstructive, for instance, when a woman has a breast or a mastectomy, then later on they hopefully will have breast reconstruction. And then it can also be used for what we call supportive care when we need to put in possibly a central line, maybe a tunnel catheter, maybe a port, feeding tubes, a suprapubic catheter. And these are the different ways surgery can be used. As far as chemotherapy, chemotherapy is the use of chemicals, as we already said, toxic chemicals that kill the cell, and they're introduced into the systemic circulation. And so when we use these toxic chemicals, there's two major categories of drugs. These are listed on page 259. They are called cell cycle phase nonspecific and cell cycle phase specific drugs. And so we're not going to actually learn all the various classifications of the chemo drugs or the chemo drugs, but just know that chemo is often used for solid tumors and your hematologic cancers. They are infused into the systemic circulation, and hopefully what they will do is reduce the number of malignant cells that is associated with the actual cancer. So as we said, there's two different categories of drugs, the cell cycle nonspecific and the cell cycle specific. The cell cycle nonspecific drugs actually exert their effect on the cells during all phases of cell activity, including the process of cell replication and proliferation. And then the cell cycle phase specific chemos just exert on their most significant effects during specific phases of the cell cycle. Typically, these drugs or drugs from each major category are given in a combination therapy. Just know that when chemotherapy is being prepared and handled, it has very specific criteria for the preparation and handling of chemotherapy. Okay, these drugs are regulated by OSHA. They are considered an occupational hazard, and so they come with OSHA regulations. The drugs, when someone is preparing them or handling or administering them, can be absorbed through the skin, and they have to actually be prepared at a special vacuum or ventilation system because they can be inhaled during preparation. Okay, only trained nurses can actually give chemotherapy drugs. So only trained nurses can actually give chemotherapy drugs. Know that when your patient is getting chemotherapy, that IV is the most common, and we have to be extremely cautious when we give IV chemotherapy, and we'll talk a little bit more about that. But also know that these drugs are excreted in the body fluids of the patient who is receiving them, so there has to be careful handling for 48 hours after the administration of the actual drugs. We are going to stop here. This last slide says nursing care of the patient with cancer. We're going to spend the majority of our time in class talking about patients that are receiving chemotherapy, radiation therapy, and the biological and targeted therapies, and focus on the nursing care of these patients.